In this skill, I'm going to be doing an advanced cardiac assessment. So the first thing I'm going to do is I'm going to gather my supplies, which would be my stethoscope, and probably some alcohol to clean off my stethoscope. Next thing I'm going to do is I'm going to go into my patient's room, knock on the door. Hi, I am Alyssa. I'm your student nurse. I'm going to be doing an assessment of your heart today. The reason we're going to be doing this is we just want to take a listen and make sure that everything's beating correctly and we don't have any abnormal sounds or nothing looks like it's not supposed to. So first thing I'm going to ask you is about your history. So do you have a history, or does your family have any history of heart issues?
Yes, my mom has heart disease and high blood pressure.
Okay, do you have any history of any heart issues?
No.
Okay. Do you have any symptoms of heart problems, like shortness of breath? Are your ankles ever swollen? Do you ever have any chest pain? Or sleeping up with pillows under your head so you can breathe, anything like that?
No.
No sleep apnea?
Uh-uh.
Okay. Do you have any replaced valves or any surgical history?
No.
Any history of diabetes or abnormal heart rhythms?
No.
Okay. Do you smoke or drink alcohol?
No.
Okay. Do you have a diet high in fat? Or is your diet okay?
I would say it's high in fat.
Okay, what about exercising? How many times you exercise during a week?
I don't really exercise that often. I go for walks.
Okay. What about medications? Are you on any blood pressure medications, diuretics, blood thinners, birth control, aspirin?
I'm on birth control.
Okay. All right. So, I'm just gonna take a look at your chest. I'd have you put on a gown and pull it down just so I can see everything that I'm looking for. So first thing I'm going to be doing is looking at your precordium, which is basically your chest area. So I'd be looking if there were any kind of pulsations or any skin discrepancies, any color differences, if it were cool or warm. The skin turgor was okay. Taking a look at those jugular veins and making sure that those aren't distended. And then I'm also going to be looking at that point of maximal impulse, which is the 5th intercostal space, midclavicular on the left side. So in a thin patient like her, I might see some pulsations, which are normal for someone who is thin. If I was seeing them on someone who was not as thin, that may be cause for concern to let the physician know. Next thing I'm going to do is I'm just going to feel your chest. I'm going to feel just around your chest, make sure I don't feel any kind of pulsations. I would feel by your sternum. I would feel all of those areas. And I'm feeling for those pulsations, which are basically little vibrations. Again, being thin, that can be normal for you. I'd also want to see if there are any heaves or basically like a lift with your systolic. So when the blood is being pumped out, I would want to feel if, there's any kind of lifting. It would be easier if she were in a gown, but I would just feel around the chest to make sure I'm not feeling any of those. Also going to be feeling around, making sure that I feel everywhere that I'm supposed to. So basically, the base, which starts by the 2nd intercostal space. So the heart would start here on either side of the sternum, all the way down to the 5th intercostal space, to make sure that we're not having any cardiomegaly or inflammation or anything like that. Make sure that the heart's in the right place. So next thing I'm going to do is I'm going to take a listen. I'm going to auscultate. So the areas I would want to auscultate are basically where we felt. So that 2nd intercostal space, I would feel, for me it's easier to feel along the sternum for those bumps. So I would feel for that 2nd intercostal space, so I can feel there's one here, and this is the second one here. So I would listen on the side of the sternum, under the gown of course, in each spot. So the first would be our aortic. Second, over here, second intercostal space. Next to the sternum would be our pulmonic. And this is the base of our heart up here. So what that means is this would be our S2 sound, our dub at the base of the heart. And this is basically diastole, where the ventricles are repolarizing. After that, down to our third intercostal space. So again, counting down to our third, that would be Erb's point. And then fourth intercostal space would be our tricuspid valve, and fifth would be that mitral valve. Except for the mitral valve, you want to kind of go midclavicular. That's also known as the apical pulse, also the PMI. So the tricuspid and mitral valve, the two lower ones is going to be the apex of the heart, and that's where we're going to be listening to systole or our lub. So once I have listened to my aortic, pulmonic, tricuspid, and mitral valves, I would want to listen with both my diaphragm and my bell. So the reasoning for that is the diaphragm you want to push a little bit harder to hear, and then the bell you can usually hear better with. So you want to push very lightly and be able to listen with both sides on all of the areas. So after that, we'd want to listen to the apical pulse for a full minute. Again, that's on that fifth intercostal space, midclavicular. And then I would also want to listen to her radial pulse, which would be on her radial artery, and for a full minute. So once I've listened to both of those for a full minute and felt her radial for a full minute, I want to compare them and make sure that they're equal. If they're not equal, that could be a sign of some kind of dysrhythmia, like AFib. Going back to my heart sounds, I think I only explained S1 and S2. So again, the apex is having the S1 sound, which is our lub. S2 would be our tricuspid and mitral valves, which is the dub. If there were S3 heart sound, this is not necessarily a bad thing. If someone is an athlete, or if they have, a really good exercise routine, they could have that S3 heart sound. But if you can tell, or by someone's history, that they're not having, if they're not exercising like that, S3 heart sound might be the start of something, kind of like a mitral valve problem. And this would sound kind of like a gallop. And then an S4 heart sound, you would listen for an S4 heart sound. This might be indicative of heart failure or aortic stenosis. So that's kind of like a for sure sound most of the time. And these are all things you'd want to let the physician know about, of course. So we've inspected, we've palpated, we've auscultated, we found our apical and radial pulse to make sure that they're equal. Some of the things I'd want to be listening for when I'm listening to my heart sounds would be a murmur, which is turbulent blood flow. This is graded on how loud it is from 1 to 6. Stenosis versus regurgitation. Stenosis is a stiffening of the blood vessel, or a narrowing of the blood vessel, usually due to some kind of cholesterol buildup, or heart disease. And it's kind of like a high-pitched sound because it's kind of narrowing that blood vessel. And then regurgitation is backflow. So you'd want to listen to this at the apex of the heart, which is, again, the fifth intercostal space, midclavicular. And this kind of sounds like a blowing sound, where the heart is just kind of pooling because it's not going through, it's just kind of coming back up. And then finally is a pericardial friction rub. The Littman app that comes with stethoscopes is really good to hear the heart and lung sounds. They're pretty clear on there. it kind of sounds like squeaky leather. This could be indicative of an endocarditis or infection because when the heart is beating, it's kind of rubbing on that outer sac that it's in. So the way you'd want to listen to this is you would want to take the diaphragm of your stethoscope, have your patient lean forward so it brings the heart closer to the chest wall, and you just want to listen in your spots for that kind of rubbing sound. But having them lean forward brings the heart closer to the chest wall. So as for inspection goes, other than at your heart, you want to look for any kind of insufficiency, both arterial and venous. So you do this mostly by looking at skin. So skin normally wants to be pink undertones, warm, dry, good skin trigger, things like that. Cap refill, less than 3 seconds. We don't want to have any kind of blue, pink, red, sweating, cap refill longer than 3 seconds, ashen, things like that. So with venous insufficiency, they might have edema. It might be really warm. The pulses might be really, really hard to find, or they might have no pulse at all. Usually we're looking at this in the legs and the feet. They might have really tough skin, superficial ulcers. They might have cramping. It would feel better if they elevate their legs, things like that. As for arterial insufficiency, they may have thready pulses, and you may need to use a Doppler to hear them. They would probably be cool, pale, dry, thick nails. They would have an absence of hair on their legs because that oxygen isn't really getting to their legs. Whereas in venous, it's kind of all getting down there and not coming back up. So it's kind of pooling. So that's why it's all red and warm. Whereas arterial, that oxygenated blood isn't getting down to the legs. So it's going to be that cool, pale, dry. Also with arterial, they might have numbness and tingling. They may have intermittent claudication, which is pain with exercise. And their legs would feel better when they're in a dependent position. So the last thing I would want to do is I want to have my patient lay down, or when I'm getting them up in the morning, and do orthostatic vital signs. So I'd want to take their blood pressure and their pulse while they're laying down. I would want to do the apical for a full minute, along with all my other heart sounds, full minute. And then once I have those vital signs, I would have them stand up. I would wait 3 minutes, and then I would do their vital signs again. So a drop in 20 on their blood pressure systole, or a drop 10 on their blood pressure diastole, or an increase in 20 on their pulse would be positive for orthostatic vital signs, which is basically when they stand up, they're not getting what they're supposed to be, and they are at risk for falling, passing out. And we just really want our patient to be safe. We don't want them to get up and fall down. We want to make sure that when we send them home, they're safe to go home, and they're able to do that without harm. So that's all I have. Do you have any questions?
No.
Okay. We gotta talk about that diet and exercise.